There is a small topic added to the title, upper airway obstruction. So, chronic obstructive pulmonary disease with upper airway obstruction. So there are two components of the COPD. One is chronic bronchitis and one is emphysema. Emphysema and chronic bronchitis are the two most common conditions that make up COPD. So, what is the most common cause?
Smoking.
Good. The most common cause is smoking, and there are other risk factors, which is industrial exposure, for example, mining, cystic fibrosis, usually see in young girls, alpha-1 antitrypsin deficiency, intravenous drug use, immune deficiency syndrome, vasculitides, and connective tissue disorders. Histological changes are irreversible and they usually progress over time. In chronic bronchitis, there is diffuse hyperplasia of mucus glands, there is hypersecretion and bronchial wall inflammation. Now, X-ray chest, the findings are non-specific. Okay? There will be bronchial wall thickening, which can happen in any inflammatory disease. Enlarged vessels at the end, and sometimes when there is, for so many years the patient is having and it's untreated, it can give rise to fibrosis and bronchovascular irregularity. The heart is usually enlarged in chronic, very long-standing chronic cases. Now, on your right side, there is a normal subject, and on your left side, you see that it's not a radiological term, but the doctors, they say dirty lungs. So you can see that on the left, the lung is not clean. It's blurred. It's grayish, whitish. It doesn't look clean, as if there is dust, a lot of dust. So this is actually a patient who is known to have chronic bronchitis. But just by X-ray, you cannot say that this patient is having chronic bronchitis. And if you look at the heart also, it is a little bit toward the biggish side. It's not big, but. So emphysema involves usually, and it is actually the definition, that it is destruction of the alveolar septum and pulmonary capillary, leading to decreased elastic coil and resulting air trapping. So pulmonary function tests reveal the airflow obstruction. Now there are different clinical phenotypes: emphysema predominant or airways predominant or mixed. In airways also, whether small airways are involved or large airways are involved. So how does it manifest? Hyperinflation. If you take a chest X-ray, you will see hyperinflation. You can count too many ribs, and the heart is tubular, and possible, if there is long-standing or a complicated one, bullous formation. Okay, destruction of the architecture is destroyed, and there is bullous formation. And if you look at the patient even, you feel that his anterior posterior diameter is not as the usual person is having. So it's a barrel-shaped chest. Now you see the anterior posterior diameter of this patient. It's too much increased. And if you look at the chest X-ray, how are the diaphragm? They are not dome-shaped. Usually they are dome-shaped, but they are not. And look at the ribs, you can count too many ribs. And the heart is towards the tubular side. Now look at the dome-shaped diaphragm, the normal one. Look at the heart, and look at the emphysema one. His heart is somewhat tubular, and look at the diaphragm. They are very flat compared to the normal subject. And the blunting of the costophrenic angles usually you will see in the emphysema people. It may not be fusion, maybe just fluid thickening. Now, which one is normal? The right one is normal. So what's going on the left?
You have flattening of the diaphragm.
You have flattened diaphragm, tubular heart,
Expansion,
somewhat expansion, but there is a specific thing I want to show in this one. If you look at the left part of the chest, you see these bronchovascular markings?
Yes.
And look at this portion. Do you see any lung marking here? No. So this is a big bulla. This is bullous formation.
What's a bullous like?
Huh?
What's a bullous?
You'll come to know in a while. So, asthma. Can you diagnose asthma by chest X-ray? No. It is clinical. Okay? You ask the history, you take the history, you see the symptom, patient is wheezing, allergic to dust, allergic to cats, whatever, and that patient is having a significant wheeze, and then you give him Ventolin and he improves. What does it mean? Asthma.
What about emphysema? Can you diagnose it just from X-ray?
Pardon?
Emphysema. Can
Yes.
you just diagnose it?
Yes, you can. All this what we saw was emphysema and the chest X-ray. So rarely pneumomediastinum as a complication can be seen, and I will show you one case. And focal attenuated changes, actually, if you see hyperattenuation or whitish band, but you don't follow it like a vessel will go towards the hilum, that is a linear atelectatic change. Okay. Sometimes we call it plate atelectasis because it looks like the edge of the plate. Now you see that there is air along the heart, okay, in the pericardium. So this is pneumopericardium. Here you can see trachea, but anterior to the trachea there is also air. You see this black line? So this is air outside the tree of the area, of the air. Neither it is in the trachea, nor it is in the alveoli, nor in the bronchi. So this is pneumomediastinum. Okay? So this patient is known to have asthma, and this is one of the complications, but it's rare. Okay? Now on the CT we do, you know that when we take CT, we do 5 millimeter thickness cuts. 5 millimeter, then we go down 5 millimeter, then 5. So, but high resolution CT we take 1 millimeter, and that's why we call it high resolution. That gives you very good anatomy and very good clear surface of the lungs, and you can diagnose whatever disease is there. So whatever we see on CT of lungs, which is bright in the lungs, we call it high attenuation area, okay, or hyperdense. Okay, whatever is dark, we say low attenuation. So hyperdense and hypodense. Okay. So what are the things which we see low attenuation area in, or low attenuation disease, low attenuation zones is emphysema, lung cyst, bronchiectasis, and honeycomb. And all are given here in the diagram. In the diagram, you can see that these are low attenuation areas, and this is high attenuation areas. These are also called ground glass opacity. Okay, these are also called ground glass opacities. Now, look here. This is a normal lung, and this one is a high attenuation or ground glass. Look here, this is ground glass. But this CT, we usually do CT scan the patient inspires, take a deep breath, hold, and then tuck, 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 and 1 minute is done. But sometimes we want to see trapping, like in early emphysema or sometimes asthma. So we ask the patient to expire. Stop, and then tuck, 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 tuck. So this is an expiration, and you can see that there are some abnormally low attenuation area. So this is air trapping. Clear? The red arrow is showing you air trapping. So, since asthma does not show you findings, so it reduces the sensitivity of diagnosis by chest X-ray. So conclusion is that chest X-ray does not diagnose asthma. Okay. Now this is a study in Finland, it's a very old study, but there was acute asthma exacerbation of these patients, and 50% of the chest X-rays they showed finding, which is quite a high number in this study. Usually it is not. And as I said, in conventional, you know now the difference between high resolution and conventional CT. So before going to further details of high resolution, you must know the basic anatomy of the secondary lobule. What is a secondary lobule? Okay. So it is about 1 to 2 centimeter and made up of 5 to 15 acini, and I will just show you one acinus, how it looks like. The respiratory bronchioles in the lungs terminate in acini. Okay? And they are many lobe sacs containing groupings of alveoli like this one. Now you see, we have just only one acinus. So you will copy the lecture and then you will see all these slides. So this is one lobule. Okay, the yellow one, of course the lobules are separated by septa. Okay, and along the septa, the tubular structure which is running is lymphatics. Okay, and inside what is goes is the airway, the bronchus bronchiole. Then there is a vein and there is an artery. Okay, so the vein is carrying oxygenated or deoxygenated? Oxygenated. And the artery is the vice versa. So if in the center of this lobule is suffered by, or emphysema is invading only this area, so this will be called centrilobular emphysema. Okay? And centrilobular emphysema, where it will be in the upper lobe, in the lower lobe, or in the middle, upper lobe. So centrilobular will be usually in the upper, and panlobular will be in the lower lobe. Absolutely. So if it is along the septa, these destruction of the architecture, and you see that these the disease is along the septa or along the pleural line, thoracic pleura or along the diaphragm, that will be called paraseptal emphysema. I will show you in a while a schematic drawing which explains it. So low attenuation pattern, you know that if there is fibrosis of the lung, okay, it will attract towards itself the bronchial tree. And so that will be dilated, elongated, and that is called traction bronchiectasis, because it is because of the fibrosis. It has been pulled. Okay, so this is how it will look, traction bronchiectasis. If it is all along the periphery and there are too many lobules like this, so it looks like honeycomb, and this is called honeycomb. Okay, If it is, you see, you have so many lobules and it is in the center of the lobule, so it is centrilobular emphysema. Okay? So the low attenuation lesions are they are manifested by emphysema, lung cyst, bronchiectasis, and honeycomb. Correct? So what is emphysema? It is actually the destruction of the alveolar septum and the airspace is enlarged. Okay? And there are variety of distribution, as we already said. So the centrilobular emphysema is predominantly seen in the upper lobe. The panlobular emphysema predominantly in the lower lobe. It does not mean that the other lobes are not involved. But I say predominantly. And if it is along the pleural line, along the diaphragm, and along the septum, along the lung fissures, major fissure, minor fissure, that is called paraseptal emphysema. So I just edit this slide so that now this is a very good schema and explains by diagram all what I said. So almost the whole lobule is involved, and it is mainly lower lobe, so that is panlobular. Now this is a lobule, this is septum between the lobule, and you see that only the central portion is involved, so this is centrilobular emphysema. And paraseptal, you see it is along the pleural line, which is along the septum, so this is paraseptal emphysema. And this you will see not on chest X-ray but on CT scan, and that even also on the HRC, high resolution. Okay. So now look there. So this is the pleural line, and you see that there is emphysematous changes. There are septa, and along the septa you can see there are emphysematous changes. So this is paraseptal emphysema. And what is a bulla? Bulla is an area of emphysema which is larger than 1 to 2 centimeters. Okay? If it is less, it has another name. And it can cause ruptures, and it can cause spontaneous pneumothorax. Now again, this is the same structure. Oh. Okay. So centrilobular emphysema, you can see that you can see the lobules, and the center of the lobule is involved. So this is centrilobular emphysema, and if you see these dots, these are the centrilobular vessel, usually out. Okay, and this one, well, again, this is the same thing, along the pleura, along the septum, and so this is paraseptal emphysema. Now you see that you are below the bifurcation of the trachea. So you are in the lower part of the lungs. So you are far away from the bronchial division, and the upper portion is normal, but you see that the lower portion there is no architecture of the lungs, there is destruction, emphysematous changes. So this is a panlobular emphysema. Now, joint bulla may lead to compression of the mediastinal structures, okay, because there is air in it, and it's a balloon, so it can compress the structure. So, what is blood? Rupture of the pleural blood may produce spontaneous pneumothorax or pneumomediastinal. Usually it causes pneumomediastinal. So we will see in a short while, and I've already told you. But which one is normal? The right one. Huh? The right one is normal. The left one, these two are emphysematous changes. This X-ray is whitish because under exposure. This technique. Otherwise, you see that the diaphragm is flattened, the heart is tubular, okay? There is blunting of the costophilic angle. So, and you can count too many ribs. So this is emphysema. Now you see that if the lung is normal, you will see the architecture, you will see the bronchovascular markings. But when there is destruction, you don't see anything. You see here, architecture is destroyed. So this is emphysema. This is how it will look like. Now which one is normal, which one is abnormal?
Left, Imam.
Which one is normal?
Left.
The left. And the right one, you see that there is no architecture, there is no lung marking here. So this patient is having emphysematous changes. Now which one is normal?
Right.
Who said this? Who said all the four are normal? Yes, correct. All four are normal. So I just want to show you that there is, you are at the level of trachea, so you are very high. Then you are at the level of bifurcation, and then there is a division of the upper lobe which goes, so one segment, another segment. And then you come down and you have bifurcation of the left bronchus with upper lobe and lower lobe. And then this is even lower than that. Okay? And here you see the middle lobe division. It looks like this one. But here you have heart. And here you have two bronchi. So this is upper lobe. And here it looks like upper lobe, but you are not at the same level. You are at the level of the heart, so this is the middle lobe. Okay? This is how the anatomy. Yes?
Why is there hyperattenuation in the right lung fields in the lower two pictures? Anteriorly, there is hyperattenuation.
Okay. This is a good question. You see here, there is no lung marking here. You see here? So this is fissure. And sometimes the minor fissure on the right side, since it is going like this, and you are cutting the whole fissure, so you will see a huge area of lower attenuation. That is normal. You will see all the cuts, the whole lung, one by one, so you will find that, oh, this is normal. Okay? So if you cut the fissure, you will have lower attenuation. So alpha-1 antitrypsin deficiency is classically associated with pan-lateral emphysema, and although it can be seen in smokers without alpha-1 antitrypsin deficiency, especially in the elderly people. But almost always it is most severe in the lower lobes. In severe pan-lobar emphysema, the characteristic HRCT, what is the HRCT? High resolution CT appearance is that of decreased lung attenuation or low lung attenuation. And redistribution of the blood vessels, because in the lower part of the lungs, the lung is destroyed because of pan-lobar emphysema. So the blood vessel, the blood has to go somewhere. So since more lung is in the upper portion, there will be redistribution of the blood vessels, and you will see too many vessels going upward. So this is one of the cases. You see that you are almost finishing the heart, you are starting the level of the liver. So you are in the lower part of the lungs. So this is pan-lobular emphysema. And this is, you can see on the chest X-ray also, that we have very little lung markings. See here, now if you have turned into soft tissue windows or mediastinal windows. This is liver actually. Okay, so this is the extreme lower portion of the lungs, and you have so much destruction with a bullous formation. So bleb is similar thing like bulla, but it is small, no larger than 1 to 2 centimeters. Okay, so they can also rupture and can cause spontaneous pneumatitis. So there was a study done, and it shows that CT is as good as the pulmonary function test. Okay, this is a small portion added at the end, upper airway obstruction. So many cases you will see that the patient comes and he cannot breathe, and there is laryngeal edema, and he doesn't have any disease. And if you take the history, either it's the bee sting, okay, or some other allergies. For example, he has taken antibiotics or some other medication, and he got, especially in the third world countries, a lot of penicillin is used because it's very cheap, and other medications like ACE inhibitors. Chemical burns and reactions, epiglottitis, usually in infants. Fire or burns from breathing in smoke, breathing the fire smoke. Okay. Foreign bodies, I have seen a few cases in pediatric. They have inhaled this 25 halala or 50 halala coins. You will see one of the pictures will show food inhalation, and people have died from food inhalation. So injury to the upper way is one of the causes. Peritonsillar abscess and retropharyngeal abscess is more common in pediatric group or in the adolescent. Throat cancer in elderly patient, and tracheomalacia, it can be congenital, but it can occur in elderly patient. Softness of the trachea, it's very soft, so when he's breathing, it closes and so the patient is having obstruction. The middle lobe bronchus, I've seen many cases, middle lobe bronchus malacia, and the patient is having middle lobe atelectasis. So atelectasis should have a cause, but there was no cause, and finally we found out that it was because the middle lobe bronchus was so soft that it got collapsed. Okay? This is called thumb sign. You see that like a thumb, it is pressing the airway. The epiglottis is enlarged, and you can see it looks like thumb. This is called thumb sign. Okay? Here you can see that the trachea is pushed far away from the vertebral column, and this is what is it? Retropharyngeal abscess. Another mass lesion. It can be retropharyngeal abscess as well, but it can be any soft tissue tumor. But this is pediatric. In pediatric, we usually see abscess or infectious process. But in elderly or in adults, you cannot exclude tumors. So you do CT scan or MRI, but usually CT scan and you see things. So this is a coin, you see. I've seen in the stomach, I've seen coins in the bowel, because it passes them. So, but that was in the esophagus. This patient is having in the trachea, and I've taken it from literature. They said that it was removed by school. So I think this is, yeah, adenoid is very frequently enlarged, and you can see that. Now you see this border, it should be as like this regular border, convex. It should be convex here. Okay. okay? But you see that there are indentation, extrinsic impression. So this is because adenoids is enlarged, it's a pediatric, okay? So because of adenoid enlargement, there is obstruction. Sometimes there will be a mass lesion outside, like this one is in the lungs, a huge mass, and it compresses the trachea. Okay, so that is an external factor of the upper airway obstruction. Sometimes in amyloidosis, there is thickening and there is a mass-like structure, and it causes obstruction. So, which emphysema is this? Pan. Which emphysema is this? Parasite. Good. You passed. Can somebody take it?